Well, for formality's sake, my name is Carl Trevenin. I'm an LGPC. I'm president-elect of SAGE, MD, which is who's putting on this whole shindig. And I'm a trainer and an advocate and an educator around LGBTQ issues and affirmative care. It's a big passion of mine. This is going to be a particularly fun presentation because not only do I get to present information that I just think is really helpful to clinicians, I also get to do it through the lens of my own experience as someone who just got top surgery. So I can kind of speak to what the process is like firsthand while also kind of having a generalized presentation for you all, which I will share now. So yeah, keep your mics muted. We'll definitely take questions throughout. Feel free to throw them in the chat. If it's a small group of us, you guys can also just ask when prompted. All right. The sun is right in my eyes. Oh. Technical difficulties, one moment. There we go. Vic said in the group, what a good group, or in the chat. All right. Okay, so like I said, we're going to be talking about top surgery and what that entails, what the components are, and letter writing and things of that nature. We're going to talk about what exactly top surgery is, what the major forms of top surgery are. I am not a medical professional, so I do not admit to being any sort of expert on this, and obviously did a ton of research in exploring my own options and things of that nature. And then we'll talk about letter writing and just kind of preparing clients for top surgery. So what is top surgery? So top surgery is a subcutaneous mastectomy. And we do want to differentiate it from the kind of mastectomy that you would get if you had something like breast cancer, because there's not the same kind of effort made to ensure that all breast tissue is removed. And I say this just because when working with queer clients and just checking in about their medical care and things of that nature, we want to keep in mind that they do need to continue to get mammograms and be mindful that there is still breast tissue available for, kind of illness and things of that nature. So that's kind of the medical understanding of what top surgery is, but ultimately it's the removal of one's breasts and some component of kind of chest masculinization. So there are multiple different types of top surgery or procedures that are done. I'm going to review the top three just so you're kind of have a vague sense and a basic understanding of what they entail. So the first is the keyhole, which works best for smaller breasts. During the technique, a small incision is made under and across the lower border of the areola, and that's how the breast tissue is removed. And that's why it requires kind of smaller breasts to have this procedure done. So it involves the least amount of scarring, which is why some people prefer it when they have the option. However, it does tend to be kind of less masculinizing because the areolas are not, there's no nipple graft, so they're not really relocated. So they don't end up sitting exactly where they would on an AMAB's chest in terms of the fact that they are higher and wider on a male's chest than on a female's. So then there's the succumer areole and the periareolar that are for medium-sized breasts. That is where essentially there's a circular incision made the whole way around the areola, and that's how tissue is removed. That slightly larger ring means that there is slightly more scarring and it's more visible. Nipples are then reattached. So this one is the least common of the three that I saw in my research, and yet it is still a common procedure. And then we have the double incision. And so the double incision is needed for like clients with larger breasts. And it's a horizontal or a U-shaped incision is made kind of along the pec line. And that's how breast tissue is removed, and, you know, fatty tissue and things of that nature. And then another incision, well, two other incisions are made to remove the nipples. They're kind of reshaped usually to, and like resized to be more masculine. And then there is a nipple graft that's conducted. So this is actually the procedure that I had. And although it says that there are kind of like the U-shaped incisions along the pec, you can actually opt to get straighter incisions, which is what a lot of non-binary humans are doing because it is less masculine. It's more kind of ambiguous, and so that fits people's identities. However, those who are trying to get the most masculine appearance will typically get the U shape along the pec line. It tends to kind of enhance the look of pecs. And again, because there's a nipple graft, the resizing and the reattachment is able to be kind of an optimal masculinizing position. So now we're going to talk about like who gets top surgery, like who you might be seeing, you know, why this is coming up for them. And so we're going to talk about the fact that both like trans individuals within the binary and those who are gender expansive may consider top surgery. And so for the transgender community, when they're like actually fully transitioning from female to male and are identifying as male, that is part of a larger transition process. Usually there's hormones and other things involved in that process. And there's now kind of the option. So originally when surgery was being made available, and then as it started being covered by insurances, it was only for trans individuals who are identifying within the binary. And that's something that we've seen some changes in, which is great. So now people who are non-binary or genderqueer can also opt into top surgery. So I myself identify as genderqueer. I don't plan on doing any other processes or, you know, medical procedures in any sort of pursuit of masculinization. I was just very, very uncomfortable with having breasts. It did not fit my identity and the way I kind of viewed myself. And so it's interesting because you may talk to clients and it's very clearly about the fact that they are male and the fact that they are wanting to be as physically male as possible and have their body fully aligned with their gender identity. And then you may have people who are doing it more so that, I mean, it's still in alignment with their gender identity, and it's less about appearing in any particular way or being perceived in any particular way, and more about, you know, comfort and the parts of their body that make them feel like themselves. And just to kind of elaborate, the term gender expansive or even gender diversity are used to encompass both like binary and non-binary trans members. And so when, you know, kind of talking to clients, gender expansive is the most inclusive way to talk about these things. So as I'm, you know, using words like transgender and non-binary and things of that, that is, you know, kind of more colloquially what those who are pursuing the surgery are being identified as or with, and a necessity of even getting surgery and how we're viewing it in the realm of counseling, for better or worse, is as a diagnosis available in the DSM-5 of gender dysphoria. And so it defines it but you can be diagnosed as both an adolescent and an adult. And it's a marked incongruence between one's like experienced and expressed gender and their assigned gender. And then there are a few other components of what the diagnosis entails. And so it usually they have to get, you know, have two of these other kind of markers. And so that is that marked incongruence. There's a strong desire to be rid of one's primary and or secondary sex organs. So that would include breasts. A strong desire for to have the like kind of primary or secondary organs of another gender. A strong desire to be treated and viewed as an alternative gender. a strong conviction that one has the typical feelings and reactions as as an alternative gender. And in order to like meet criteria, the condition, as it's put in the DSM, needs to be associated with distress and like disruption in one's life, and it needs to last for over 6 months. So now we're going to talk about assisting gender diverse clients in this process, kind of like before and after surgery. So first steps are going to be securing a diagnosis of gender dysphoria. So that's not something that all agencies do right off the bat. They'll do evaluations or whatnot. And even if that is kind of something that is showing up, because that if that's not identified as the primary reason for seeking services, they'll usually be assigned an alternative diagnosis. And so there does need to be this intentionality of documenting gender dysphoria as a formal diagnosis. Now, a lot of kind of doctors and insurances don't require any documentation of the gender dysphoria beyond what is included in the letter. And sometimes it does come up. So this is something that you want to be considering documenting, and documenting as soon as you can, because obviously there needs to be, a history. And so if you're meeting with a client, even if they have an alternative primary diagnosis and you are recognizing that they fit the criteria for gender dysphoria, kind of getting that in within their paperwork early on can be really helpful. So next will be, kind of working on the letter with your therapist. And so we'll talk about the letter writing process and what that entails. But that is usually necessary to get pre-approval from insurance, and or if you're going out of network, or if you're just pursuing someone because you don't have insurance, most surgeons also are going to require a letter. So that ends up being necessary both with and without insurance involvement. Then there's finding a surgeon. So this is something that clients can do through their like insurance website, but again, not all clients have insurance. So, and not all insurances, are able to or willing to cover it depending on the criteria that they have set. And so this is going to be just, kind of a Google search. And I definitely recommend looking at pictures or instructing clients to look at pictures of before and after. That'll give you a really strong sense of if their way of conducting surgery kind of matches what a client is looking for. And also talking to other people. So I'll bring that up a lot, having them connect with other gender expansive humans, particularly those who have done or gotten top surgery, as a means of getting names. It's very kind of like community oriented. There's a lot of information sharing that happens amongst the community. And so social media can be a really great way to start getting names and, finding these things out. And when it comes to finding a surgeon too, they can request consultations. They can meet with multiple doctors. So that can involve going, talking, asking your questions, see which doctor you're most comfortable with, look at their before and after results, and then make an informed decision after that fact. Then there's payment options. So this is the part that is unfortunate about the surgery, is that it can be difficult to acquire financially. The cost is averagely about $6,000 to $10,000. My surgery was almost $9,000 to get. And so if you don't have insurance, something like Care First can be a really good option. So that's something that is good to be aware of for clients, because that is essentially a credit agency specifically for medical reasoning. And then you can kind of make payments instead of having to pay all up front. The care credit will pay up front, because that's the thing, is that the surgeons are going to want the payment all at once, understandably. And so that's a way to take off some of that financial burden. Then when it comes to insurance, we need to be looking at if it's covered. And so we'll talk a little bit about that in terms of ways to find out if it's covered and how to go about that. And that process, so I really suggest having clients call and ask for the LGBTQ specialist at their insurance company. Not all insurance companies have them. When they do, it's very helpful. well. So asking to speak with someone who is familiar with kind of gender affirming surgery in the process. And then there's usually, they'll be able to kind of walk you through to the section of your benefits that talks about exactly what criteria needs to be met in order to get the surgery covered. And then you can usually get some sort of pre-approval. It depends, because it's an outpatient surgery, meaning that you can go home right after. A lot of insurances don't require pre-approval. That will depend on the agency themselves. And so this is all information that your client needs to know beforehand. And so this is just things that you can encourage them or assist them in finding out and in exploring. Also with, when it comes to insurance, they'll specify on that list how many letters people need, and if there's any other kind of requirements such as hormones. So this is something that when surgery was originally starting to be covered, again, I said it was, mostly for trans individuals who fell within the binary. And so having a hormone treatment was a prerequisite to getting top surgery. That is something that has changed and isn't a requirement for most insurances at this point. And it's still something to look into, because we don't want our clients getting to the point where they are thinking that they're going to be able to get surgery and get it covered, and then finding out that there's, some barrier that they didn't see. Find out what is required by doctors and insurance. That's what I was just saying about kind of going through the available information that's online. It can also be helpful if you talk to someone to have that conversation documented, just so that you have a demonstration of, what was given to you in terms of prerequisites and things of that nature. And then finally, considering whether emotionally and physically prepared. And so we're going to talk about that in more detail in a little bit, about, what does that mean? What do clients need to be prepared for? What kind of work can you do with them as clinicians to get them to that point? All right, so now we're going to talk about letter writing. And this is probably one of the most helpful sections of this presentation, because most of you should be able to write letters. So who can write letters is determined, again, by the insurance company and or the doctor, if they require letters. However, for the most part, it is any clinician with a master's degree. So you just need to be a master's level clinician. And so mine was written by a social worker. I know counselors who have written them. So this is something that most of you can do. And so then it's just a question of being able to, via having the knowledge and the comfort to do so. Now, if for some reason you aren't comfortable or just don't feel that you have the information in order to write a letter for a client, that is okay. There are agencies around that will do kind of like one-offs, where they'll meet with a client, 1 to 3 times just for the letter writing process. And it can be helpful to know what those agencies are in your area, should you not feel comfortable writing letters at this time, because that's a pretty easy way to for a client to, seek a letter if their primary therapist can't or isn't able to. So when it comes to letter writing, we need to talk about gatekeeping in particular, because it's a very helpful thing for you to talk about with your clients as part of the letter writing process. So gatekeeping is essentially this idea that you as clinicians, since you are writing these letters, are in control of the client's ability and right to seek gender affirming medical care. And I'm sure that you all have noticed in your work that when it comes to oppression and groups that are oppressed, we often see kind of policing of the body. And this is another way that is happening, because I could go to a surgeon and get a breast enlargement without a letter. I could get any other physical changes to my body for whatever reason and not need any sort of permission to do so. And yet, in order to have my breasts removed, I need permission from a therapist. And just thinking of the implications of that, that again, and this is true of it being in the DSM in the first place, which we do want there to be some sort of code for, again, insurance purposes and getting medical treatment, things of that nature. And the fact that that code is not really a medical one, it's a mental health one, does send a certain message, and having to get permission from a therapist in particular over just a medical professional can also send a message about, you know, what it means to be diagnosed with gender dysphoria and what it means to be seeking these kinds of services. And so it's really important that you as therapists acknowledge that you both acknowledge that gatekeeping is a thing that's happening here, and to some degree denouncing that process, making it clear that this is not something that you agree should be happening, and yet it is. And so talking to them about the fact that you are there to support them, that you are not a barrier to them seeking these services. You are there to help make that happen. And that's what the letter writing process is. And so you want to tell their story in a way that will get them what they need. You are asking questions in order to properly tell their story versus, you know, interrogating them or having them prove to you that they, you know, have a right to seek these services. So the specific insurance site will clarify exactly what needs to be said in the letter. So as a clinician, when you are letter writing, it's important that you get the insurance or, you know, go to the insurance site and look at that list to make sure that you are covering everything in your letter. Now, these are kind of the general components that show up. So first is just client's general identifying characteristics, including diagnosis. So that's like, you know, the typical stuff of age, race, things of that nature. And that's where you would include the gender dysphoria diagnosis. Now, we need to be mindful about other diagnoses that we are listing. So some of this is a bit nuanced in that working with insurance, as I'm sure all of you know from having car insurance and other things like that, is that there perhaps is a tendency to not want to pay as an insurance company if you don't have to. And so we need to be mindful of ways that insurance companies can deny a claim or, you know, just creating barriers for our clients. And so part of some of the information that is put out by insurance companies or whatnot about getting top surgery does essentially say like clients can't have any significant trauma or, you know, and what they're getting at is like consent and someone being cognitively capable of consenting to this treatment. And so we just want to be mindful when we're listing alternative diagnoses or when we're talking about our relationships to clients and the work that we're doing with them, that we are being honest, but being careful about the information that we're presenting and how we're presenting it, and making it clear that any other diagnoses that are at play are not affecting the client's ability to consent, is not influencing the decision in any way beyond just being related. You know, if the client has depression or does have PTSD, that makes a lot of sense considering that they are living in a body and in a world that is not affirmative and working for them. And so again, just something to be mindful of. So like I said, a statement of informed consent. So this is, you know, saying that you totally agree with the client's decisions, that you think that they have the judgment capable to, you know, determine that they require this surgery and that you are in support of that. Next is the duration and nature of the referring health professional's like relationship with the client. And so this is where it can be helpful if you yourself can write the letter for the client, because it is helpful when there is a longer term relationship that can be noted. I haven't heard of anyone's claim being denied because they went and did like the one-off assessment for the diagnoses and for the letter. And we just want to be mindful and careful of the ways that we can create barriers for clients inadvertently. Then there's the explanation that the criteria for surgery has been met. And so these are the things that are listed by insurance companies as being necessary. This is also discussing kind of the clinical rationale for supporting the client's decision, and just any kind of related information about the backing the reasons and speaking to the fact that they have been met. And then finally, a statement that the referring health professional is available for coordination of care. So should the insurance company or the surgeon themselves want to follow up, it is helpful if you provide that information and are willing to speak to that. So I'm actually gonna, if you guys want to give me 1 second. So I'm going to pull up the letter that was written for me for surgery, just to give you an idea. I've blacked out any kind of particularly private information, and I've highlighted these components that I just spoke about and where they show up. So I'm going to bring that up for you all just so you can kind of see. All right. So you can see, normal introduction. They explain who I am. They give my full name and birth date, which you all don't need. And then it talks about, so I'm here to document the medical necessity for gender confirmation surgery. The surgery is indicated for the treatment of gender dysphoria. So the diagnosis is listed there, and it's actually listed, multiple times throughout the letter itself. So they talk about, there's the WPATH, which is the standard of care for the health of transsexual, transgender, and gender nonconforming people. And so that's where a lot of this information about the components of letter writing come from. And insurance companies do use this, which is why there is mostly consistent requirements for letter writing. And so that's actually an organization whose standards of care you can refer to also as your letter writing and just supporting gender expansive clients. So then there's my identifying information: 28, Caucasian, genderqueer, masculine presenting individual. So another thing to be mindful of that is kind of a nuance is that, because again, the history of it being a trans binary procedure, there have been some issues with insurance companies when clinicians use gender neutral pronouns. So even though I use they, them pronouns, I actually went through a process with my therapist of whether that was going to be okay or whether we needed to use male pronouns throughout the letter. So this is something, again, that you may have to communicate to clients and, again, denounce that, I'm sorry that we're essentially misgendering you in this letter, and we're trying to get you the care that you need. And so we're going to do what we need to. And luckily, my insurance company, that was not a particular problem, but I did end up getting the letter with both male pronouns and then my actual pronouns of they, them. And so that's just another nuance that is unfortunate and yet something to keep in mind. So then it talks about, the history, documenting that it's, this has been over 6 months. Insurance companies / surgeons like to know that this has been an ongoing experience. So it talks about persistent, well-documented gender dysphoria, capacity to make a fully informed decision, and gives consent for treatment. And again, she references the WPATH standards. It continues to document just, my history with gender. So they indicated that they cut their hair short and started wearing more masculine clothing around 7 years old and felt more comfortable presenting more masculinely since that time. And then down there, it says, since that time, they've had a strong desire to be rid of them in reference to my breasts, explicitly stating the process to pursue gender confirmation surgery 5 years ago. And so that's helpful in just, again, making it clear to the gatekeepers of this process that this is something that's not a new idea, because for some reason, there is an idea that anyone would want to go under major surgery on a whim. Some insurances want you to kind of speak to client readiness. And so my clinician honestly had a kind of pre-written script for this section, which she more just kind of checked in with me about, like, okay, you've done your research. Yes. So there are ways that you can make this process a little less overwhelming for clients by having kind of standard things that you put in here and then just kind of confirming that with them. So again, it doesn't feel like you are making them prove that they have looked into this. And so that's this section: describe a double mastectomy procedure in detail, pre-op preparations, the surgery itself, recovery and care. They described extensive research, looking at pictures, watching videos, and reading blog posts, most of which I did actually do. So this is where I talk about kind of being careful. You know, my history was documented here. And then she made it very clear, I have no concerns about this interfering with their ability to make decisions about surgery. And I do believe that they are ready for surgery. And so that's something that we need to make very explicit if we're going to include any other kind of mental health history. And then this last part is just a summarizing sentence with that component of, I'm available to answer any questions or provide further care coordination. Feel free to call me at this number. All right, can you all see that okay? Oh no, spinning wheel of doom. All right, well, while we're at this point where my computer is deciding to freeze, which is awesome, do we have any questions? Is there anything, or just comments about anything that's been discussed so far? And you can throw that in the chat. It's easier for me if you can just share if you're willing. Also, it looks like we may be frozen.
How did you and your therapist figure out that? Can you hear me?
Yes. Okay, I can now. How did my therapist and I do what?
Figure out that they, them pronouns was okay for your insurance company, or how was that determination made?
Yes. So this was kind of a roundabout process that my therapist had a supervisor who basically works with insurance companies and does kind of letter writing and this kind of like affirmative care. And so she had knowledge of which insurance companies were being particular about pronouns and presentation. So what I would say is that when you look at what the insurance company is asking for, pay attention to language, because they will say, like, identifies as the opposite gender. And they will use words within the binary. If that's the case, it's likely that they're going to want to hear those, either he or she. And so just being mindful of that language. Whereas other insurance companies, when you're looking at that list, they will say something like an alternative gender or another gender. And so even just paying attention to that language will kind of clue you in, if not just calling the insurance company directly and clarifying with them. Any other questions or comments?
Sorry if I missed this. I'm going to assume, but I don't want to incorrectly assume, that Medicaid covers this, or no?
It is my understanding that Medicaid does, and I don't know that for sure.
Okay.
So that's something that you would just want to check in by going to the Medicaid site. More and more there is, so in Maryland, I think that there is a necessity for insurance companies to cover like gender affirming surgery. And so like Maryland Medicaid should.
Okay. All right. Cool.
All right. If you can just.
And when you said to be mindful of a trauma diagnosis, does that mean that having a concurrent trauma diagnosis is really a don't do that? Or is it just, if there's a concurrent trauma diagnosis, be really careful to document in the letter that trauma doesn't impact the individual's ability to consent to the surgery?
So I would say that to some degree that's up to the therapist who's writing the letter and their comfort. If it feels that it goes against any kind of ethical principles or anything like that to omit the diagnosis, then including it needs to talk about how, essentially, as when I talked to my therapist, it was that it needed to highlight that like significant trauma work has been done, and that essentially the PTSD diagnosis was on its way out, kind of languaging, and that it wasn't at all affecting my decision making and things of that nature. And so that's what's really interesting about it is, again, there's not solid rules for a lot of this. And so if it feels necessary to document for whatever reason, just making sure that you're doing it really carefully and talking about how this is being dealt with, that the client is currently in therapy, that you're doing work on it, that it's not affecting their ability to consent, and so on.
And is this something that you have to be mindful if the client has like a lifetime, like they've been given a trauma diagnosis from a previous clinician, even if you don't at your agency or in your practice, do you have to address that, or does the insurance company not necessarily know?
So the insurance company won't necessarily know. So some of the, like, again, it's like languaging. So some of the languaging on that list that insurance has put out do ask for like all diagnoses, or uses language that implies that they want more than just confirmation of gender dysphoria, or like if there is something else, like they want to know about it. And others just state like, we need to know that gender dysphoria is the diagnosis. And so again, you can use that to guide you in terms of what to include. From my understanding, it isn't a history. Like, I haven't read anything that has spoken to a history of diagnoses. So if this was like a former diagnosis or something that you yourself would consider like in remission or not a primary or active diagnosis, then I wouldn't even entertain including it. It's just about kind of current diagnoses and presentation, because again, they are interested, or their reasoning is that whatever they are currently diagnosed with may be affecting their ability to make sound decisions.
Do I have time for one more question?
Yeah, absolutely.
Are there any potential cons of giving a gender dysphoria diagnosis other than the kind of general pathologizing of like gender queerness?
Yes, there is one in particular, and that is if the client is interested in military service. And that is something that will hopefully not be the case for much longer. But right now, a gender dysphoria diagnosis does make you ineligible to enlist in the military. And so I'm also a veteran. So when it comes to enlisting in the military, they don't actually like subpoena your records. It's more self-report than anything else. And so it's not necessarily like absolute that if a client is considering any sort of career in the military and that's documented privately, that would ever be something that the military would know about. And who knows? The military. So the fun thing with the military is that like once you sign that contract, you are technically kind of like the government is your guardian, and it does give them rights and access to things that are typically private or covered under things like HIPAA. And so that's the only kind of downside beyond, like you said, pathologizing, that we would want to be mindful of with clients. However, if they're seeking a gender dysphoria diagnosis because they're getting top surgery, that already, like if they're getting top surgery, the military makes you strip naked. So they're going to know before you even are able to enlist what's going on with your body. And that is going to, result in being ineligible. And I don't think that is going to be a policy of the military for any significant length of time. And so that might be something worth kind of exploring with a client if they are on the younger side and considering the military as a career. Any other questions? Cool. All right. So helping clients prepare. There are kind of three main arenas to do that in. One is preparing physically, one is preparing mentally, and one is preparing logistically. And so some of this, particularly the mental preparation, is going to be actual like clinical work that you are doing. The physical and the logistical is more about helping them, kind of build routines, accountability, and just checking in with them about what they're doing to make the healing process as comfortable as possible. So physically, being in good physical shape is going to support recovery. So clients being active and just healthy individuals is going to mean that they will recover faster, that their surgery will likely take better. Now, there's usually not issues of rejection except for in the double incision where they actually do the nipple graft. So technically, the body can reject the nipple graft. It is rare and it does happen. And it's not necessarily the fault of either the doctor or the client when that happens, but there are ways to help keep that from happening. And one is being healthy and being in good physical shape. The next thing is stabilizing any chronic health conditions. And I would say that this is true for mental health decisions as well. So when we're talking about, other diagnoses and things like that, it is important that you do, as a clinician, consider if any of their other diagnoses could actually be affecting their ability to consent or just affecting their ability to psychologically handle the surgery at that time. And so you want to consider whether they are engaging in these logistical and physical ways of preparing as a means of understanding whether they are ready to pursue this and whether any other diagnoses may get in the way of their ability to cope and recover well. And that doesn't necessarily mean that it is your right to deny them this medical care. And as their clinician, if you have a strong, rapport and are well connected, hopefully, bringing up these concerns would allow you to do this work so that they could be, most prepared. And next is like just body movement and exercising before surgery. It increases blood circulation and core strength, which are just, kind of helpful things to have after surgery. So, if you have a client who in the future wants to get top surgery and you're trying to find ways to have them build a healthier routine or include, positive coping strategies, this is a good way to encourage movement and exercise. And then reducing or stopping substances at least 2 months before surgery. So this is another thing that you'll need to be mindful of in terms of like comorbid or concurrent diagnoses is ones around substance abuse, because that can definitely affect healing and things of that nature. And in particular, what we need them to stop is nicotine. So the other things aren't helpful to recovery and will certainly complicate things. However, nicotine is actually poses the greatest threat because it really, really reduces blood circulation and oxygen getting to tissue, which is essential for healing. And so that's where that like nipple graft, which I talked about, that can be affected by nicotine use. And just generally the healing process can be affected. And so if you have clients that struggle with substance use or abuse, to include smoking and use of nicotine, that's something that you're going to want to work together to address before. And, as we know, kind of like behavioral therapies can be really, really helpful in doing that. And that's why that is something that as a clinician, you should be mindful of, because you can be really helpful in the preparation period physically when it comes to, like I said, both exercise and the reduction or stopping of substances. So next is mental preparation. So this is where you all can be the most helpful and will need to do the most work. So first off is just clarifying with clients surgery goals and their hopes and their fears and their expectations. having space to voice these and process them is incredibly meaningful going into surgery. And it does support recovery because there is some anticipation of, you know, what this is going to feel like and look like and things of that nature. And understanding their expectations can help with, you know, deciding between whether other kind of affirming medical care needs to be conducted, whether, you know, even what type of surgery they want to get, or like what type of incisions they want and things of that nature can be helped by understanding what they're going for and what their goals are. So if they're looking for the more masculine chest, then the way that their incisions are made can enhance that. And those are things that they're going to need to communicate with their doctor. Next is anticipating post-surgery stressors. So it's important to talk about, okay, you're going to be lying in bed or sitting for at least a week. And then you're not going to be able to you can't lift your arms above, above anything. You can't lift them for several weeks after surgery. You can't lift anything above 5 pounds for, I mean, it depends on the surgery, but usually like the first, 3 weeks. And then you can't lift anything above like 10 pounds for the following 3 weeks. You can't exercise. The only thing that you can do really physically is go for walks. And so that was like a particular stressor for me. So exercising is one of my primary coping strategies. And so dealing with just regular stressors, even not, surgery specific stressors for that 6 weeks after surgery did pose more of a challenge. And so it's helpful to, if you know that exercise or just like even any of the kind of like major physical, ways of engaging are major coping skills, then there needs to be a discussion about alternative coping skills that can be used during this time and other ways to manage stress. And then it's also about what do we think is going to be difficult about this process? So for me, I had anticipated I am not always the best at asking for and receiving help. I knew it was going to perhaps be a challenge for me to not be able to function independently, to have to rely on others, to have to ask for someone to hand me things. And for the first week, you can't shower. And so like my mother came to care for me for that first week, and she had to bathe me with a wash rag and help me wash myself. And so like thinking about those things and like what that means psychologically and what that feels like to not be able to care for yourself in the ways that you usually can do like add stress to this process. And so thinking about things like that, like what it'll mean to, be taken care of, and how effective people are at asking for what they need, which I'll talk about in a second. The fact that they won't be able to really move or exercise. You also can't drive for the first week or two. So we'll have to think about these things in terms of work as well. So depending on what kind of job you have will determine how quickly you can go back to work. So I think I had surgery on Tuesday, and I definitely saw clients on Friday. So telehealth was helpful in that. I just waited until I wasn't in need of any sort of like pain medications that would alter my ability to practice. And then I was not in any sort of significant discomfort at that time. And my job requires sitting at a computer in my house. So I got back to work very quickly. However, if you have a more active job, a job that requires any lifting, that can't be done. If it requires like lengthy standing or driving, that is going to be more disruptive. And so thinking about what that means for work, getting that time off, and also what that means in terms of like finances and things after, if that's going to affect paychecks in any significant way, with these additional stressors in mind. And so again, if you're having people caretake, that means less time alone. That means more, interactions with people. And so that might be a stressor depending on the individual. There's also like, if anyone has any sort of like anxiety or ADHD or anything going on, having to sit for extended periods of time, like a full week, is also really difficult. You should be able to keep taking psychiatric medications I was told like the day after surgery, you could return to medications. Now, obviously, you're going to want to have them check with their doctor and psychiatrist and surgeon about that. And for the most part, there isn't a ton of concern. So you're going to want to have them practice stress reduction exercises, have them review coping skills, um, have them, you might want to up sessions if they can, especially while we're doing telehealth, or if you're a community therapist and you're like going to your clients, that might be something that can be really helpful in terms of giving them a space to emotionally experience and cope with your support. And so just being mindful that recovery, it's surgery and it's stressful. There's also, some level of pain, and you're not sleeping much because you can't roll over. You have to sleep like with pillows on both sides of you, and so only on your back. And so sleep can be disrupted. Things like that are important to review and anticipate and discuss. And so the things that I just listed are pretty general and will likely affect most clients. And so you'll want to, specifically talk about those things, like the people involved in work and things of that nature. And also talk to them about, just what specifically they're worried about and what comes to mind for them. And if you work with them intimately, like if you're their regular therapist, then you probably also have a sense of what might be difficult for them in this time and what might come up as stressors. And so just having that conversation with them. So also with the fact that, so for recovery, you're not really able to move much or do anything for that first week. The second week, you can get back to a fairly regular routine minus any physical activity. Again, work schedule, depend on what kind of job you do. So planning activities for recovery, like, do you have books you can read? Do you have TV shows you've wanted to catch up on? Kind of anticipating that there's going to be a lot of time. And what we don't want clients doing is filling that time with worry. And so let's plan for the fact that you're going to be sitting and lying for an extended period of time, and like what can be done for entertainment purposes as, again, a means of reducing stress and making recovery more comfortable. Then you're going to want to evaluate support. So this is something that you're going to, like, the moment clients are bringing gender identity concerns to you, you're going to want to check in about support, which may look different from the supports that they have in general in their lives and around mental health things. You may have a sense of what their support looks like, but when it comes to their decision to get top surgery, that may be influencing who is going to be there and in what way. And so you're going to need someone to be present at the hospital or the outpatient facility when you go to surgery. And so an important question to ask is, who do you want there when you wake up? So you're going through the surgery, you're going to wake up in pain, disoriented, with a mixture of excitement and confusion. You're extremely vulnerable. So who is it that you want to drive you home? Who is it that you want there? That person is also going to be instructed on kind of the immediate aftercare and signs to look for, if there's any sort of problems with the surgery and things like that. So obviously you want someone that you trust and that you're okay with being there, because they're meant to stay with you for that entire first day. So they will drive you home and then they will stay with you. So we want to talk about, the support system as a whole, and then specifically who's going to be there in that moment when things are most difficult. My first day out of surgery, like, I needed to be essentially like fed and given a straw up to my mouth to drink and things. And so luckily I had my mother there who was lovely and willing and able to do those things for me. And so it is very vulnerable. It is very, infantilizing? Is that the right word? And so choosing someone that you are really, really comfortable with is going to be important. And in fact, surgeons won't move forward if you don't identify someone ahead of time who can stay with you for that entire first day. Now, after that, care is kind of intermittent. You can't really move your arms very much. So you're still going to need someone to prepare food for you, to, like I said, help with bathing, help with changing clothes. I could use the bathroom independently, so thank goodness for that. But there are a lot of ways that you are going to need support. And so it is helpful to have kind of somebody around for most of the time for those first 4 or 5 days. And so that doesn't have to be the same person. And if that's the case, then scheduling those people ahead of time. So who are the supports and when can they be available, and actually mapping out, okay, this person's coming at this time, this person's coming at this time, and really kind of like a coordination of care, because we don't want clients really alone for any extended period of time, because then if nothing else, they'll try and do something that they shouldn't and injure themselves or just make themselves uncomfortable. You're also going to talk about like communicating needs. So if you have like interpersonal effectiveness skills at your disposal, you're going to want to make sure that your clients have those, because they're going to need to communicate around asking for help and having needs met. And a lot of people struggle with that. And so making sure that your client knows how to effectively have their needs met and is willing and able to communicate when they need assistance is going to be a really big part. And so some of that might just be like about like the actual skill of effectively asking for help. And some of it may be that kind of psychological processing around like, what does it mean to you to have to ask for help? And how are you going to feel when you have to do that over and over and over again? And when any sort of feelings of shame or discomfort arise around that, how are we going to deal with that? And how are we going to cope with that? Because we have to be asking for help, because you can hurt yourself and you can make the healing more difficult for yourself. And so that's going to, be an important component of the recovery process. And then finally, then this is kind of more for my own personal experience, also preparing them for like the unreality of what's about to happen. So like I said, you do all this prep work, you get a consultation, they kind of map out what the plan is, you make all your payments, you get things pre-approved with your insurance company. If you need to get your letter, you send all of that in, and then they clear you for surgery and they give you a date. On that day, you are usually given some sort of like anti-anxiety medication, and then a medication so that you will not become ill with the anesthesia and the painkillers that you'll be put on for the procedure. So you take that usually before you even go in. Once you go in, they obviously have you change into the like dressing gown that you're going to wear for the procedure. Your person that's with you, even so I got this done during COVID, and even with that, I was able to like have someone with me for this process, at least, kind of like before I went back to the surgery table. From there, I went back. They kind of explained how the anesthesia was going to work and like what the process was going to be and things of that nature. And it was just like kind of putting the mask on with the anesthesia, and then like having the IVs and stuff put in. And then it kind of goes black from there. It is wild how quickly these things put you out. My next memory, I was kind of coming in and out after surgery. I dealt with a lot of confusion about what was going on. They were trying to get me to drink water and some juice after. And I just remember being really confused as to like why people were doing that. There's also, like the person that you opt to have there is there. There's, kind of bustling doctors and nurses and whatnot. And so it is a bit disorienting. Also, you have a binder of sort that they put you in after surgery that's padded. And so this is something that I didn't know about or just really think about before I went into surgery, is that when I woke up and kind of came to, it felt and it looked like I still had boobs. I felt like I was wearing a bra. It's padded, so it looks like you still have boobs. And I was convinced that they hadn't actually conducted surgery. Now, my reasonable mind understood that obviously I had. I had been there at the surgical office. I was in pain. And I was really struggling to put that together, especially because, you know, it's confusing like to one's mind, but it's also, I feel, confusing to the body because it feels differently. You know, what's going on with your chest feels differently, and yet you haven't been able to kind of like lay eyes on it. And so there's not that like connection between mind and body that's been severed temporarily. And so I found myself experiencing some level of almost dissociation. And so I think with clients too that have a trauma history, which many, if not all or most um, queer clients and gender expansive clients who are getting this surgery have, there is an even greater likelihood of an experience like dissociation. And so I really struggled mentally in ways that I did not anticipate for that first, 3 days, where I couldn't kind of connect my body to my mind. I couldn't wrap my head around and really convince myself that they weren't there. So again, new on a cognitive level, and yet on an emotional level was really struggling and really disoriented. And of course, the fact that you're on pain medications doesn't help that process. Now, the pain is fairly minor. So this is something that I found in my research, that I found in talking to other people who had gotten top surgery and then experienced myself, is that the pain is not particularly significant. In fact, a lot of surgeons won't even prescribe opiates or anything of that nature. They will just prescribe kind of really strong Tylenol vibes. So I had a very low grade opiate, and I did appreciate that in terms of sleeping. And I could see, like I said, by day, whatever, 4, I was able to work because the pain was not disruptive and I wasn't needing to take pain meds anymore. So the pain is actually fairly manageable. There is mostly just like discomfort, and then the inability to move was really difficult. So for those first few days, I am really struggling with the kind of unreality of it all. I'm in physical discomfort. I can't do things independently. And it was very, very challenging at first. I needed someone to kind of be in the room, and yet didn't really want anyone around, which certainly got complicated. And so that's the thing too with having caretakers, and what you may want to clarify with clients is that the caretaking is particularly helpful if the person's in the room with you, because a lot of what I needed were these like stupid things like, can you hand me the remote or turn the TV up? And like, can you pass me my cup of water? And I did find that, if my mother was downstairs, I wasn't inclined to call her or shout down to her to get her to hand me a cup of water. And so I would try and do those things for myself with varying success. There was a lot of spillage. And so because is most helpful to actually have someone there, like the most likely way to encourage clients to recover safely and ask for help is to have someone immediately available. And so thinking about like not who you would just like want to or feel comfortable with taking care of you, but like who are you cool with like sitting in the room watching movies with you all day while you like fall in and out of sleep. So, just being mindful of that. So the first few days were really challenging. So you don't get to actually see your chest for a week or two. You go in for a follow-up appointment. It depends on the doctor, whether that's, like I said, at a week or from that. You also, depending on the type of surgery, you may have drains. That's very common, to drain any excess blood and fluids. And so I have this like binder on with all of this like padding in it, which chafed the crap out of me too. So that was additional pain. That was actually, those blisters, I have like scars from them. They were more painful than the actual surgery parts. So be prepared for that. I also had all these tubes coming out of me and these like sacks of body juices, which someone needs to drain. So I was able to do that after a few days, and at first I couldn't. And so again, you need someone who's fairly comfortable with blood and just being in your personal space and doing all of that. So I had those drains in for a week. After a week, I was able to go back. I had the drains removed, which is a very uncomfortable process. It feels like snakes are in your chest. And luckily it's quick. And from that point was able to actually look without the padding for the first time. And holy crap, I can not put into words the joy and the love for myself and my body that came in that moment. It was overwhelming. I don't know that the surgery felt real or that any of it felt like what the rest of my life was going to look like until that moment. You won't get to see it again very often. So I took pictures, which I gazed upon lovingly for the many weeks after. I don't know that I've ever looked at myself or been quite as vain as I was in those first few weeks, because you have to keep a compression vest on then for anywhere from like 3 to 5 weeks after that. You can take it off for showering, so that's nice. And you can, depending on the surgeon, they will say like you can't have it off for more than an hour a day, and so you don't get to see your chest. You feel like you're wearing a bra. There's the padding. It looks like you have boobs for another month. So having a picture is very psychologically helpful when I was feeling that sense of unreality, when I was feeling frustrated with the fact that I had to wear this. I didn't wear bras when I slept. So like this was worse than when I had boobs. It was really uncomfortable to sleep with. It was super disruptive. Like I said, it chafed me. It was unpleasant, and having those pictures did feel really important to kind of maintaining my psychological health during that time. So you'll go for another 4 weeks or so without regularly being able to see your chest or feel like you don't have boobs. After that point, you can take the compression vest off. Now, mind you, the compression vest is essential. It helps the kind of skin reattach to the muscle tissue and the whatnot that is below it. And so clients absolutely need to be wearing that. They can really, really damage their post-surgery body and the way that it looks if they don't. And so we need to make sure that we're holding clients accountable, especially if they are becoming really frustrated with the process. So once you take that off, you usually have to, I had a nipple graft, so I had to keep my nipples covered, but otherwise could just wear clothing regularly. And that was another huge milestone. I had quite the fashion show. I tried on, okay, like, what does it look like in a button up? What does it look like in a t-shirt? What does it look like with no shirt on? Like, wow. So many outfit configurations in order just to like bask in what it felt like to have my clothes fit me properly and to look the way that I wanted. And so that was something that was really huge and significant. And then after that, it just depends on kind of doctor's recommendation for when you can start lifting again. You have to do another post-op appointment and get cleared for that. But usually people are fully recovered in terms of like the scarring and whatnot in about 6 weeks to 2 months. And then the rest of the healing process takes about a year. So in terms of like having the like nipples fully heal and kind of take on the color and appearance that they will have, which will look like more regular nipples, it takes 6 months to a year. The scar settling will take up to a year. And the nipples actually can get, like, they'll look good after surgery, and then they usually get worse between 3 and 6 months, and then they look better. So that's something to just be mindful of if clients are like, what's happening? And yeah, and the scarring itself too, and like coloring and everything will calm down after about a year. And from that point on, you're looking great. So that's just, kind of the general process in terms of my experience to give you a sense of what clients will likely be going through and what they will be coming to you with. The final aspect of preparation is really like logistical. So making sure that you have someone to drive you home, making sure that you have everything at your house that you're going to need because you can't drive anywhere. And so gathering supplies is really important, to include proper clothing because you can't like pull stuff over your head. You need to wear like oversized button-ups. And all of this can be found, like if you just have clients kind of like Google like supplies necessary for, female to male / non-binary top surgery, all of that's there. Also, community boards are really helpful, and there's a lot of passing on. So like I got the stuff that I use, like the shirts and the padding and the medical tape and all of that, from my roommate who had top surgery. And my roommate had gotten it from one of their friends who had had top surgery. And I'm sure I will pass it on, all the stuff I have, to the next person we know that gets top surgery. So there's a huge community aspect that, you know, you can encourage clients to tap into if they're feeling overwhelmed or if these things are feeling too expensive or whatnot. You want to create a comfortable space. Again, you're like sitting and lying, so making sure you got all the pillows that you need, and, you know, different spaces that you can kind of post up comfortably to mix it up throughout those first few days. You also have to move everything down to like waist, chest level. You can't do any reaching, so like anything that's on any top shelf needs to be moved down. Anything that you use needs to be readily available, because the not lifting your hands above your head goes on for weeks. That's not just in the beginning. Notifying employer, securing time off, figuring all that out is also part of the, you know, kind of logistical process. And then meal planning. Even after, you know, at first you're likely going to need meals prepped and heated up for you because microwaves and ovens are too high. You're probably going to need someone else to be taking care of that for those first few days. After that, you can function a lot more independently. My mom left, I got surgery on Tuesday and she left on Saturday. And I didn't have kind of regular ongoing care, or like I didn't have consistent care after that point. I definitely had intermittent care. And so meal prep is huge. My mom was such a mom and made a crap ton of food and put it in Tupperware containers for me. And it was very, very helpful. So thinking of things like that. So yeah, that was a lot. I'm glad this is recorded and you're all going to get it so that you can review all this super fun information. But I do want to give us a few minutes for any sort of like clarifying questions or comments or anything that I can provide. And I'm happy to speak both to my personal experience being genderqueer, having a diagnosis of gender dysphoria, or, you know, top surgery, or things, you know, kind of more specific to generalized clinical topics that I've discussed. Oh, cool, nailed it. So yeah. Just other things to kind of keep in mind is definitely trying to have your clients connect with other people who've had top surgery. It doesn't need to be people that they know or can meet in real life, but it's huge to talk to people and get advice and connect and celebrate and, you know, get supplies from other people in the community. And it's so community oriented that if they're not tapping into that, they're really missing out on a huge social support system for this. And so like Facebook is a really great way. There are groups specific for this, specific to Maryland, specific to Baltimore, of kind of transgender expansive humans that are willing to share doctors' names and who to avoid and what to do and what to ask for and things like that. So definitely encourage your clients to reach out and connect with other people. Have resources available for them, just in terms of, you know, maybe as you work with trans clients, you know, get the names of their doctors and you'll hear about their process and keep those names in mind for future clients that are starting that process of searching for a surgeon. And then otherwise just educating yourself on other kind of gender expansive topics in care. This, you know, process of affirmative treatment isn't going to end when they get top surgery. And so just being aware of other things that might come up, even, you know, having to process what it'll be like for other people and what is, you know, going to happen in terms of family and things. You know, getting top surgery is a pretty significant step beyond just pronouns or identifying as genderqueer. And so processing and anticipating those is going to be really important. I am looking at the chat is what's happening. So currently in the military, so they did a whole, like right before the ban went into action, they said like, if you're trans and you're in the military now and you self-identify, we're going to put you on this list and like you'll be safe, you'll be grandfathered in. And that got really complicated because people were like, do I want to out myself and have myself on a list that the government has that affects my livelihood and my job? Maybe not. And so, as so far as I can tell, those people who did self-identify were not discharged. Mostly everyone else, it kind of became a new like don't ask, don't tell policy. So when don't ask, don't tell was in effect, which was while I was in the military, which was super fun, they would discharge you. That threat was made and I saw it happen. So that was a thing. That threat is similarly being put out there right now around like if you were to admit to being trans or if you were found out, which for the record, like your squad leader and your, you know, captain aren't actively trying to find this information. And so as long as you're reasonable, you should be able to keep it private. I presented the way that I did now, except for I was in a uniform. And the cool thing is that the uniform is gender neutral. We all wear exactly the same thing. So when I was in uniform, it was, my only identifying like trans characteristic was having short hair, which is also not uncommon in the military. And so it was kind of this, like, we're not going to look too closely and like just don't say anything. And people are pretty scared and feel pretty threatened, and so don't. And so I haven't heard of a lot of discharges happening. And I think that's more because everyone's being very careful and just ignoring a lot of things in order to make that happen. Because obviously the people that are pursuing discharges, many of them in the military don't agree with the policy. And so they're kind of turning a blind eye. Groovy. All right, anything else before we part? Okay, cool. So if you want to, you can jump over to the like opening tab and we're gonna do like a like wrap up vibes. And you know, not necessary for you to head there if that is not something that you're feeling able to do. This has been a long day of learning. I appreciate you all so much for being here. This information is so important. If you have any questions at all come up about this material, I'll throw my email in the chat real quick. Feel free to email me. I also do trainings on affirmative care generally and like trainings with agencies to kind of get them up to par with affirmative care in terms of space and paperwork and all of that. So if anyone's interested in that, hit me up. Otherwise, you all are good to go. And there's my email.
Call.
Yeah.